understand exactly where we sit performance-wise all the time with them. And it's something that we're working on, getting data faster from them, and unredacted data, if that matter. But just so we kind of understand the scope of these folks, this second contract, that's $14 million worth of patient spend. That's 6,700 patients. So when you start adding up these numbers, that's a lot of economic influence that we all have here. And that's important because as we move into our next version of our network, part of that's going to be how do we look at out-migration, how do we look at tightening up referrals between primary care and specialists, and how do we integrate even more with the hospital. Some of you saw that we had established a relationship with a company named Cielo Star. And Myron and administration and I were working on this, and it's a narrow network product, and it's kind of a pilot to see if we're able to actually go out to a small employer market with a product that would exclusively utilize EJ and all of you in GSQN. It's new, like all new things, it takes a little bit of time to get some traction. First step is we actually have some people looking at it. We've actually worked with 3 different agencies and we have 4 different quotes. This is a step in a new direction for us. We're excited. Just the fact that we have enough employers out there that are interested in looking at what this would be to only use EJ for its care, I think that speaks a lot of volumes. We're also finally in the beginning negotiating strategy formation with both Humana and with Aetna. This is the part where I start going faster. So one of the things that we really want to try to convey is as we look forward, what are the key things that we're looking at in terms of that next step with the network? Because there's a lot of things that we realize that over the past years, there's so many mechanics that have been happening as we kind of changed how we relate with you and how we relate with payers, that a lot of those things kind of go unseen. And I can rest assured, as some of our physicians that participate, Dr. Encini is going to talk a lot about participation, there's a lot of work going on behind the scenes to make all of these things work. First of all, we are going to continue with our overarching strategy. Wherever we can, we're aligning with the hospital, we're aligning between employee physicians, community physicians. We're going to continue to build those primary care-based chronic workflows that we've already got established. We've been working, and there was kind of a start and stop, we've been working on implementing an analytics strategy with Optum. And I know for those of you who spend too much time watching the Golf Channel, yes, Optum does own all the advertising on the Golf Channel. It's every commercial. That's how they also sponsor Warrior, just saying. And what this is going to allow us to do is basically, as we go down this road, it starts making other data assets available to us. That part of what we want to discuss about is how do we now, as we have more data, how do we start engaging more of you in looking at what this data is starting to tell us? Our first phase of implementation, which we're actually in right now, is really focused on paid claim, getting eligibility, getting pharmacy raw claim data to allow us to much faster be able to attest gap in care. And I said attest gap in care because our PCPs know what it's like when we run around saying, hey, did these guys, did they really get colorectal cancer screening? Did they really have a flu shot? And some of these other criteria. It will start giving us the ability to have a longitudinal view of how people actually move through the network. And I think it's easy day in and day out to assume that certain referral patterns happen a certain way. And I can tell you when you start looking at this data, you start seeing that that's really not happening. That somehow that patient moved outside of the EJ system. How do we find that? How do we find how they got there, and how do we bring them back into our system? The second part of this is a really big lift that is a 2020 lift, when we start looking at implementing some clinical data in this as well. And that's when it starts to really get interesting. When you're able to look and you're able to see side-by-side performance of different specialists performing the same procedure with various outcomes and the like. So that being said, what are we as we go forward? The term is enable, because part of what we've been able to do is bring together a really solid foundation that has proven to be year-over-year successful, that now we're able to bring some data assets into to really be able to take that next step. And we're going to be able to bring a lot more information to all of our physicians within the committees that will allow us to really understand what's happening. I remember when I first came here 3.5 years ago, I remember sitting in Mark Peters' office, And he says, well, you're the hot dog from McKesson from Chicago. What are the things you got to do to be successful with this stuff? And I said, well, first off, it's very simple. You got to listen to your network, right? Because how utilization occurs throughout all of you tells us something. The second thing is we have to understand the populations that we serve because the patients move differently, and it's not just because of a schedule of benefits, it's because of certain social determinants of health, as I like to talk about now. And the third thing we got to do is we have to collaborate everybody, because if you don't, it's always one-sided, and one-sided, guess who wins? The payers do. I'm going to move you even faster. So a couple takeaways. Number one, we are year over year what Blue Cross and our payers call a high-performing network. We've been at the top of all of the quality awards between Blue Cross and recognition by United. With the foundation, it includes analytics and some of this increased physician engagement with you all in our committees, et cetera. This really is a kind of a really good scenario because nothing in the market is really actively driving into risk in some of these other models. So it gives all of us the opportunity to respond to what we're learning and how we evolve versus having to sign a risk contract and then go and react to it, which is what a lot of the folks that do Medicare shared savings plans do. In the line model, it's all of us, it's hospital, community physicians, as well as our employed physician group. It's all together because that's the only way you represent the most impact into that dollar, all those big dollars we were putting up on the screen earlier. The only way to attack that is if we're all working together. And having the analytic ability to come to you all with things that we find that gives us the ability to understand what those people are doing and how they're moving through our healthcare delivery system. And then lastly, you're the key. We have to have your engagement, and I'm going to pass it off to my Dr. CD.
All right, thank you, Denise and Jeff. So it's just the last couple of slides to go before we continue to bore you. This is real important. Not only is your participation in patient care important, but we also need some help sort of in the quality committees and our regional board. I'd like to single out Dr. Dugan, wherever he's at, and show my great appreciation for the leadership that he's provided in the quality committee. In fact, the whole quality committee has done an unbelievable job to get to the point where we're at right now, and I think that nothing that we do or nothing that our patients have benefited from would happen without that particular committee. So with that being said, we had an original construct, a chapter-based committee to do the work and oversee our clinical integration programs. The chapter selected representatives that, along with the hospital executives, comprise of a member of board of managers that engage with the larger GSQN network. And to give you an idea in the hierarchy of how this all works is organizationally, you have Mother GSQN, and then you have the East Jefferson chapter, and you have the Lake Charles chapter to our west. In collaboration, both of them work ultimately to provide quality metrics that we share with our payers. However, for our East Jefferson chapter, we've looked at ways that we could find to get more engagement, participation, and also meaningful participation as far as metrics data acquisition is concerned. So we've looked at revisiting and aligning our new network with the emerging needs and capabilities that we have. More patients, more data necessitates more participation. Like Jeff talked about, Optum takes us to a whole other level of information, almost overload. And having a higher level of sophistication to process that information and provide it to the payers is going to be really important. Our current structure is a quality committee and board of managers, as I just mentioned. Prior committees included a membership committee and a payer committee. We've talked about our membership committee, and I'll read some of the things that we've discussed to explore parameters of what types of members should there be and how to address emerging market needs. Non-MD behavioral health providers are currently excluded for being aligned when they are a needed partner, and we can see that this has become a bigger and bigger topic. So in this case, we also look to see how we can include potential and essential partners and providers. Create a new definition for partnership. The current structure we have is somewhat outdated. It's over 5 years old, and it really met the needs for what we had initially to get the clinical organization up and running. Do you actively participate with all payer contracts? Do you support the aligned quality programs? So this is obviously important. You can be a member of GSQN, but you still need to be a member of some of the payers that we work with so that we can provide all that important and critical information. If not, we're not sure what role you're playing. What demonstrates an individual physician participation? The number of physicians that fail to even log in is an issue that has to be addressed. And so this is one of those things that, this is short of the easiest money that you'll ever get just by logging in and looking at a couple videos. And you must not like money if you don't want to log in. So I can't stress the importance of making sure that you participate. And if you're having any difficulties, or if you need to get your office staff to reach out to us, please don't hesitate. Today's a great day to have that discussion at your office, and I'm sure Lena and Denise would be happy to take the amount of calls that it may need to help meet that goal. Next question is, should we develop work groups to help with projects and initiatives as directed by the Quality Committee? And that's something that's come out of Board of Managers as well as the Quality Committee. We talked about in the past strategies to address the issue with certain medications, certain brand name medications that were high cost that had viable generic alternatives, and these committees have been really effective at helping with that, helping us understand how we can be a little bit more effective. So the big question is, we need you. We need help. We're looking for volunteers. I know that this has not been as intensive an organization because a lot of the things that we've been collecting are really low-hanging fruit. But as we move forward, if we don't continue to be more sophisticated and more involved, you're already seeing it with what you do with MACRA and MIPS and everything else, then you're going to fall behind and probably find yourself on the wayside, missing out on a whole bunch of financial opportunities. So with that being said, I want you all to consider seeing if you would be interested, or if you'd want to nominate somebody to help us out. Please send that nomination or interest to either Lena or Denise or me, and I'll be happy to discuss what's entailed. It's really not that burdensome, and I think you'll find it pretty enlightening and very interesting how healthcare from a payer's perspective works behind the scenes. So with that, I'll conclude our presentation. Hopefully you've got some meaningful information, and I open for any questions. All right, very good. Go get your checks.